So now my task is to discuss about the treatment of anemia, and I just start with some simple considerations. So the basis of the treatment of severe anemia consists of red blood cell transfusion, and all patients can receive transfusion except those who has an autoimmune hemolytic anemia, of course, where the treatment is quite different and the clinical diagnosis is quite different. Another option is within erythropoiesis-stimulating agents. Some of us use erythropoietin as single agent or add-on to JAK inhibition. Someone else use androgens. Danazol is a good example. There is a phase 3 study, the Momentum, that used danazol as best available therapy. So we have information from danazol prospectively. And then we can use IMiDs. I have to say that I use lenalidomide in patients who are 5q minus. That's very rare, I think 2-3% of the cases, but in this situation, lenalidomide is really quite effective. I do not use pomalidomide. I use it within the clinical trial, and thalidomide may be a good option, especially for those patients with severe thrombocytopenia, and probably it's better to combine this with low-dose corticosteroids. And then we have the JAK inhibitors that are ruxolitinib, fedratinib, pacritinib, and momelotinib. This is the list. Ruxolitinib is JAK1, JAK2 inhibitor. Fedratinib and pacritinib are JAK1 spare JAK2 inhibitor. And pacritinib and momelotinib are also ACVR1 inhibitor, so with an effect on anemia. All the 4 drugs are approved in US, while in Europe we have approved ruxolitinib, fedratinib, and momelotinib very recently. So we have to start with ruxolitinib because ruxo has the longest story, and we developed ruxolitinib on the basis of the COMFORT-1 and COMFORT-2 studies. And COMFORT-1 was a random ruxo versus placebo, COMFORT-2 ruxo versus best available therapy in first in JAK inhibitor naive patients. And here you can see the result in terms of SVR. So this SVR at week 24 has been achieved in 42% in the COMFORT-1, and at week 48 in 28% in the COMFORT-2. And one of the problem that we had managing patients with ruxolitinib or with JAK inhibitor in general is that most all patients treated within the COMFORT-1 and 2, so intermediate to a high-risk disease, are anemic, and 1 out of 2 became transfusion dependent. The JUMP study is a phase 3b study that offers us some opportunities. One opportunity is to study patients with a platelet count between 50,000 and 100,000. And you can see here on the bottom the results. So in the orange, you can see result in terms of SVR in this cohort of patients. So we can reach in this cohort of patients 38% SVR at week 24, 32% at week 48, and the same more or less at week 96. And we know that the efficacy on the spleen is dose-dependent. We know that we have to treat patients in this within this cohort of low platelet with a lower dose, so a lower efficacy is expected. The second point of the JUMP is that if we treat a patient intermediate 1, and there is a large cohort of patients treated within the intermediate 1, we can have less toxicity, less hematological toxicity. So just 1 out of 2 patients are anemic, and 1 out of 4 patients became transfusion dependent. And an update of the JUMP study and a new study from Andrew Kendall from the Flatiron analysis in the US demonstrated that for those patients who are not anemic at baseline but became anemic and received transfusions, the overall survival is shortened. So for those patients who became anemic under ruxolitinib, survival is shorter. And this is basically the same message we provided with RR6 that clearly demonstrated those patients who are transfusion dependent from the beginning and continued at month 3 and month 6 have a very worse survival, but also those patients who are not transfusion dependent at baseline but became transfusion dependent at month 3 and month 6 have a bad survival. The second drug is fedratinib that has been developed in the Jakarta 1, Jakarta 2, Freedom and Freedom 2 study. And Jakarta was in JAK inhibitor naive versus best available therapy. Jakarta 2 in patient JAK2 exposed, so Rux exposed. Freedom and Freedom 2 were studied for the second line setting, and Freedom 2 was randomized versus best available therapy. The efficacy on the spleen was very clear, very similar to that of ruxolitinib, but we observed anemia effect that was present in 43% of the patient who received transfusion, so grade anemia 3 or 4. And this was confirmed in all the studies. The third agent is pacritinib that is developed in the PERSIST-1 and PERSIST-2. The PERSIST-1 is in JAK inhibitor naive patient. The PERSIST-2 is in patient who failed JAK inhibition and with a platelet count less than 100,000. And you can see on the bottom the results. So SVR was 19% and the TSS 19% in the PERSIST-1. And it becomes, you have to see the dark orange, that is the correct dose of pacritinib, 200 milligram BID. In the PERSIST-2, so in a cohort of patients with a platelet count less than 100, SVR was 22% and TSS 32%. But again, we recently investigate also the effect on anemia, because pacritinib is an ACVR1 inhibitor, and you can see here the results. So we consider two different criteria for defining the transfusion independency. One is the Gale criteria, so no transfusion within 12 weeks, and the second is the simplified 1 criteria, no transfusions within 12 weeks, and hemoglobin more than 8 grams deciliter. And you can see here in the orange estimate that 37% versus 7% and 24% versus 4.5% were the transfusion independent rate obtained in a patient who received pacritinib versus those who did not. So the efficacy on transfusion independence was very clear also in this cohort of patients. And if we look at the patient with a very low platelet count, so the patient who are now under investigation in the Pacifica study that includes just patients with a platelet count less than 50,000, you can see that in this cohort of very difficult patients, we obtained a 23% of SVR 35 and 25% of TSS 50. So in this cohort of patients, pacritinib can really reduce the spleen, improve the hemoglobin level, and so in this cohort of patients, for instance, we can proceed to stem cell transplant with a lower size of the spleen and a better hemoglobin level. And the last JAK inhibitor that we want to describe is momelotinib that has been developed in the Simplify 1 and Simplify 2 study. The Simplify 1 was a head-to-head comparison between momelotinib 20 mg QD versus ruxolitinib 20 mg BID. And the Simplify 2 was in JAK2 exposed patient randomized momelotinib to best available therapy. And these are the results. On the left, the Simplify 1 result in terms of SVR and TSS 50. You can see that there are no differences among the two drugs in terms of SVR, so the efficacy on the spleen is the same. And the efficacy on TSS 50 was higher in those patients who received ruxolitinib. So we expect to have more efficacy on symptomatology if we choose for our patient ruxolitinib versus momelotinib. And also, the rate of patients who are transfusion independent at week 24 shows some differences. So 66% of the patients on momelotinib were transfusion independent at week 24 versus 50% of those on ruxolitinib. And if you look on the right, you can see the trend of hemoglobin that is clearly different. The blue line represents those patients who receive momelotinib, so there is an increase in the level of hemoglobin and then a stability, while the orange one represents the trend of hemoglobin in those patients who receive ruxolitinib, so the classical decline and then an increase of the hemoglobin level toward the baseline values. And this is the result of the Simplify 2, so the second line. You can see that there is no difference on SVR35 between the best available therapy and momelotinib. And you can see that TSS50 is in favor to momelotinib in the second line. And again, the effect of transfusion independence was higher in those who receive momelotinib versus best available therapy, 43% versus 21%. And if you look at the two graphs on the right that include a patient who have anemia, so hemoglobin level less than 10 grams deciliter, and those on the bottom who are not transfusion independent, you can see again that the trend of hemoglobin was an increase in the first weeks and then a stability of hemoglobin. And this happened just for those patients who started momelotinib from the beginning at the time of randomization. And the same trend is for those patients who started best available therapy and then crossover to momelotinib. So this is confirmed earlier and later in the disease. And the last study is Momentum. Momentum is a study that randomized patients for the second line setting to receive momelotinib versus danazol. And the primary endpoint of this study was TSS50, so symptomatology control. And by this comparison, momelotinib demonstrated to achieve TSS50 in 45% of the patients versus 25% of those treated with danazol. And we have also to observe that the rate of transfusion independence on the bottom of the right, the rate of transfusion independence was 57% for those patients who started momelotinib and then continued momelotinib in the study. And it was 60% on the bottom for those patients who start danazol and then crossover to momelotinib. So the efficacy on transfusion-independent rate was very nicely documented in the Momentum and allowed the authorization of the use of the drug. Concerning side effect, I want to stress your attention on the peripheral neuropathy, because this happened in 15% of the patients, mostly grade mostly grade 1 and 2. But consider this is a clinical study where we have to exclude the patient with history of peripheral neuropathy. So I suggest you to follow very carefully this patient for this side effect. And on the right, you can see the data of a pool analysis, Simplify 1, 2, and Momentum. And here you can see that the overall survival at 2 years is 76%, at 4 years 60%, and at 6 years 51%. So very nice. These are my conclusions. So we have today 4 different JAK inhibitors. In Europe, we have 3 different JAK inhibitors. Ruxolitinib, fedratinib, I think that effectively improves splenomegaly. Splenomegaly, as we discussed yesterday longly, is a very important predictor of survival efficacy. However, they can exacerbate anemia in patients with myelofibrosis. A result of the persistent stress suggests that pacritinib is effective with myelofibrosis and severe thrombocytopenia, also with a positive effect on hemoglobin. And the data from the Simplify 1 and 2 and Momentum trial indicate that momelotinib can improve transfusion independence in patients with MF and anemia, and also reduce splenomegaly. So this offers a new possibility for those patients who are anemic. And I think that a tailored approach may be necessary when we have to choose the treatment for a patient. So we have 3 or 4 possibilities. We have information that can guide our choice based on the patient profile. So I thank you so much for your attention.